Hi dear students, welcome to this class where we will be talking about AUB coin. Coin considers the coagulopathy, ovulatory causes, all the endometrial causes, iatrogenic causes and not otherwise classified. So in the coin system we undergo all the functional causes rather than the structural causes which we studied in PALM, that is polyp adenomyosis, leiomyoma, fibroids or malignancies. So let us talk about the coin classification one by one. First coming to C. C stands for coagulopathies. Coagulopathies. So what do you mean by coagulopathies? What coagulation disorders can lead to abnormal uterine bleeding? Coagulopathies which are most common are generally in the pubertal age group. Pubertal age group. This is because जिनको coagulation disorders रहता है वो pubertal age से ही उनको heavy menstrual bleeding start हो जाता है because they keep manifesting from the very early age itself. So coagulation abnormalities are responsible for around 30% of the cases of heavy menstrual bleeding that presents in the mostly pubertal age group, So how do you suspect that a patient is having coagulation disorders? Coagulation disorders are suspected. They are suspected when following signs and symptoms are present. Number 1, when there is family history of bleeding diathesis. मतलब फैमिली में किसी बुजुर्ग या किसी को भी ऐसा सिम्टम्स है कि दे ब्लीड फ्रॉम other orifices also, means apart from menstrual bleeding there can be bleeding from the nose, there can be gum bleeding, there can be bleeding per rectum or other orifices also, they keep on bleeding. So the family history of bleeding diathesis, or when patient gives history of frequent epistaxis, nose bleeding is there, then also you suspect कि patient might be having coagulopathy. Third is bleeding from mucous membranes, like your example of mucous membrane bleeding is bleeding during toothbrush, okay, bleeding during brushing the teeth also leads to gum bleeding, so this can be another history. And the fourth history is excessive bleeding following minor surgery. Excessive bleeding if patient had undergone during any minor surgery, for example your tooth extraction. If somebody had undergone any tooth extraction and during that the patient is having a lot of bleeding, then you suggest कि patient might be having coagulation disorders. Now what are the coagulation disorders which are most common? Most common coagulation disorder which is leading to heavy menstrual bleeding is von Willebrand's disease. Out of 30%, 5 to 15% is constituted by von Willebrand's disease themselves, followed by the other common ones are ITP, that is idiopathic or immune thrombocytopenic purpura. I stands for कभी कभी idiopathic thrombocytopenic purpura भी बोलते हैं, कभी कभी it is called immune thrombocytopenic purpura, okay, means immune mediated can also be there. It can be because of any platelet function disorder also, means platelet count is normal but the platelets are not able to have any coagulation effect. Then it can be factor 11 deficiency is also very common in India. Factor 11 deficiency, factor 8 and followed by factor 7 and factor 9, that is hemophilias are also very common in India. Hemophilias and all over the world also, even the royal family of England is also suffering, the kings are also suffering from hemophilias. Okay, so hemophilia can be other causes. So this is all about coagulopathy. In coagulation disorders, the treatment will be you have to supplement the required amount of coagulation disorder which is not present in the body. Suppose it is factor 9 deficiency, you have to give factor 9 externally. If it is factor 7 deficiency, you have to give factor 7 externally. But sometimes पता नहीं चलता है कि कौन सा factor deficiency है, then you can give fresh frozen plasma to the patient because plasma will contain all the clotting factors. Okay, if it is factor 1 deficiency, that is fibrinogen deficiency, then fibrinogen deficiency के लिए specifically you can give other products like cryoprecipitate. I have spoken this in my abruptio placentae class, so you can just refer to it when I was speaking about DIC. Okay. Now the next thing after coagulation disorders which we will be talking is about ovulatory causes. Ovulatory is O. Palm coin COO. Now what do you mean by ovulatory causes of bleeding? Ovulatory causes of bleeding consists of two types of bleeding. Okay, this is also called DUB. DUB is dysfunctional uterine bleeding. Dysfunctional uterine bleeding is defined as subset of AUB. मतलब abnormal uterine bleeding का ही एक subset है where there is no structural cause, detected. Okay, मीन्स कॉज पता नहीं चल रहा है, सारे टेस्ट करा लिया, ठीक है, आपके बाकी स्ट्रक्चरल एंड लेबोरेटरी, यू कैन यूज लेबोरेटरी ऑल्सो, लेबोरेटरी टेस्ट आर ऑल्सो नॉट डिटेक्टिंग what is the cause of AUB, then you say it is DUB. So basically the ovulatory are the causes where investigation में कुछ पता नहीं चलता है and ovulatory and E, okay, AUBO and AUBE are the diagnosis of exclusion. सब exclude करने के बाद finally ये पता चलता है. तो ovulatory causes can be of two types. Either it can be because ovulation हो ही नहीं रहा है body में, so it can be because of anovulation, or it can be because of ovulation, but ovulation is also leading to AUB, ovulation AUB or ovulatory AUB can also be there. Now as the name suggests, coming to anovulatory type of AUB, anovulatory type of AUB ये है कि body में ये ovary है and these are the follicles which are getting recruited. So once the follicles get recruited, they become dominant follicle and then pre-ovulatory follicle, and then they rupture and they become corpus luteum. So if this process is hindered, and the follicles rupture ही नहीं होते हैं, then it is called anovulation. So the classical example is PCOS, polycystic ovarian syndrome, whereby the follicles do not become dominant, they remain in a size of 2 to 9 mm. Dominant follicle, I have already told in my previous classes that when the size is more than equal 10 mm, then you say that it has become dominant. तो dominant होते ही नहीं है, वो follicle pool में रह जाते हैं, recruited follicles, and you find a lot of follicles arranged in necklace pattern around the ovary. So they are called cysts. Now they are called cysts. So there are cysts, multiple cysts are found. Because of this anovulation, what actually happens is all the follicles will be secreting estrogen, estradiol, and since corpus luteum is not formed, so there is no progesterone in the body. So there is tonically increased estrogen, first half of the cycle में बढ़ता है, and then estrogen कभी कम ही नहीं होता है, estrogen is always high. And progesterone is never there. So what happens is endometrium becomes thicker and thicker because estrogen is there, and it comes to such a level that after which the body is not able to sustain this thick endometrium, and then it keeps on sloughing and it keeps on bleeding every time. So patient has heavy menstrual bleeding for a long time because the endometrium is keeping on shedding all the time. These are called breakthrough bleedings. These are called breakthrough bleedings. Breakthrough bleedings. I have already spoken about introductory class to AUB. Breakthrough bleedings will be there. So this is what is anovulatory type of bleeding, and the classical example is metropathia hemorrhagica. Metropathia hemorrhagica. Metropathia hemorrhagica. Okay. Now coming to ovulatory type of AUB. Ovulatory type of AUB means patient is ovulating, ovulation हो रहा है, but still patient is having abnormal uterine bleeding. This is classically of two types. This is classically of two types. Very, very important. Just listen to it. One is irregular shedding. One is irregular shedding. Irregular shedding. And the second one is irregular ripening. Irregular ripening. Now what do you mean by this? One more thing I would like to stress upon here is anovulatory type of bleeding constitutes 80% of the AUBO, whereas ovulatory type of AUB consists of 20% of total of AUBO. Okay, so most of it is PCOS, of course, but anovulatory type of bleeding can also be found sometimes. So how do you know that a patient is ovulating or not? If the menstrual cycles are regular, menstrual cycle is regular, patient is telling हर महीने time से ही bleeding आता है, then you say that patient is ovulating. Because if patient will be ovulating, then after ovulation I told you the next 14 days of the cycle is constant, क्योंकि corpus luteum का लाइफ स्पैन 10 days है, 8 to 10 days. So once patient ovulates, then bleeding is inevitable कि menses तो होगा ही. So that is why once patient is having ovulation, then patient will be bleeding, so cycles will be regular. Okay, so remember this. Now coming to ovulatory type of bleeding. Ovulatory type of bleeding I told can be of two types, irregular shedding and irregular ripening. Coming to irregular shedding. Irregular shedding is also called Halban's disease. Irregular shedding is also called Halban's disease. Halban's disease. I am talking this in detail because you get exam cases on AUBO. Short cases, gynae cases in Halban's disease or ovulation or anovulation. So you have to know what is it. Okay. Halban's disease, the pathology, where is the pathology? Irregular shedding. Now see, this is the menstrual cycle. Okay. Here once bleeding has occurred, this is where ovulation has occurred, and this is where another bleeding is occurring. Let us consider patient has 28-day cycle and at day 14 ovulation has occurred. Now what happens, the pathophysiology is that there is persistent corpus luteum after the cycle. So here the corpus luteum was formed and corpus luteum यहाँ पे आते आते day 25 पे corpus luteum degenerate हो जाता है. बट इनका प्रॉब्लम ये है कि कॉर्पस लूटियम डीजेनरेट नहीं होता है, तो कॉर्पस लूटियम बहुत लंबा टाइम तक परसिस्ट कर जाता है. सो परसिस्टेंस ऑफ कॉर्पस लूटियम फॉर अ लॉन्ग टाइम विल लीड टू दिस डिजीज. सो द मेंस्ट्रुएशन कम्स ऑन टाइम, क्योंकि कॉर्पस लूटियम है यहाँ पे, इस टाइम पे मेंसेस तो आ जाएंगे, मेंसेस विल स्टार्ट इन दिस टाइम बट इट गेट्स प्रोलॉन्ग्ड. तो इस टाइम पे भी पेशेंट को मेंसेस आएंगे. सो पेशेंट को मान लो मेंसेस आते हैं 4 days का. इनिशियली पेशेंट यूज्ड टू हैव 4 days ऑफ मेंसेस. नाउ शी विल हैव 4 days ऑफ खुल के आएगा. उसके बाद पेशेंट को स्पॉटिंग एंड थोड़ा बहुत ब्लीडिंग होता रहेगा फॉर द नेक्स्ट 7 days ऑल्सो, बिकॉज कॉर्पस लूटियम सही से डीजेनरेट नहीं हुआ. सो व्हाट हैपन्स, since the corpus luteum is continuing, So what happens, the progesterone level is not falling at a same time, progesterone level is not falling at a same time, वो धीरे धीरे करके बहुत दिनों में फॉल होगा. एंड सो एंडोमेट्रियम जो है अचानक से शेड नहीं होगा, वो धीरे धीरे करके बहुत दिनों तक शेड होता रहेगा. सो दिस इज द पैथोफिजियोलॉजी. सो हिस्टोपैथोलॉजी, सो हाउ डू वी डायग्नोस इट? डायग्नोसिस के लिए इन्वेस्टिगेशन क्या कराते हैं? इन्वेस्टिगेशन इज दैट यू हैव टू टेक एन एंडोमेट्रियल बायोप्सी on day 5 or day 6 of the cycle. Remember, day 5 to day 6 of the cycle mein you have to take an endometrial biopsy. Why day 5 to day 6? Normally if you take an endometrial biopsy on day 5 to day 6, what type of endometrium will you get? You will always get a proliferative endometrium. Proliferative, what do you mean by proliferative? First half of the cycle में मैंने बोला था ईस्ट्रोजन ज़्यादा रहता है, तो ईस्ट्रोजन के इफेक्ट में क्या होगा? प्रोलिफरेटिव एंडोमेट्रियम होगा, जहाँ पे ग्लैंड्स कम होंगे एंडोमेट्रियम का. एंड सेकेंड हाफ ऑफ द साइकिल इज गवर्न बाय प्रोजेस्ट्रॉन विच इज सिक्रीटरी एंडोमेट्रियम एंड इट हैज़ गॉट अ लॉट ऑफ ग्लैंड्स फॉर सिक्रीशन. सो फर्स्ट हाफ ऑफ द साइकिल डे 5 डे 6 पे करेंगे तो जनरली ईस्ट्रोजन कवर रहता है, तो प्रोलिफरेटिव एंडोमेट्रियम रहना चाहिए. बट हियर व्हेन यू डू इन दिस पेशेंट हु हैज़ इरेगुलर शेडिंग और हैल्बेन्स डिजीज, here you will get a mixture of proliferative plus secretory endometrium also. secretory जबकि नहीं होना चाहिए इस टाइम पे डे 5 डे 6 पे, लेकिन यहाँ पे रहेगा क्योंकि कॉर्पस लूटियम सही से डिसइंटीग्रेट हुआ नहीं और वो प्रोजेस्ट्रॉन सिक्रीट किए जा रहे हैं फॉर अ लॉन्ग टाइम. सो दैट इज व्हाट इज द investigation of choice. Endometrial biopsy histopathology has to be done at day 5 to day 6, which shows a mixture of proliferative, तो it's okay, but secretory endometrium भी रहता है. What is the treatment? What treatment you have to give? Treatment is nothing but NSAIDs. You have to give NSAIDs to the patient so that it is a self-limiting process, and you have to give NSAIDs for 6 months during the menses. During the menses you give. धीरे धीरे क्या होगा? बॉडी का फिजियोलॉजी गेन हो जाएगा, and NSAIDs will help in regulating the corpus luteum function, and so corpus luteum will regenerate at its time. The second disease which I was talking about is irregular ripening. Irregular ripening. Now irregular ripening disease has no special name, like irregular shedding का Halbes disease था. Irregular ripening का as such कोई name नहीं है. So here the pathophysiology, remember again 28 day cycle हो गया, मान लो day 14 पे ovulation हो रहा है, वो तो normal होगा. बट हियर द प्रॉब्लम इज दैट पहले वाले में क्या था? कॉर्पस लूटियम बना था और वो लंबा खींच गया था. अब कॉर्पस लूटियम बना और वो जल्दी डिसइंटीग्रेट कर गया. ओके, कॉर्पस लूटियम शुड हैव मेंटेन टिल डे 25, बट हियर इट इज डिसइंटीग्रेटिंग इन 2-3 दिन में कॉर्पस लूटियम खत्म हो गया. सो इन दिस कंडीशन द एंडोमेट्रियम रिसीव्स इनएडिक्वेट सपोर्ट फ्रॉम प्रोजेस्ट्रॉन. सो इधर ईस्ट्रोजन से तो थिक हुआ था, बट प्रोजेस्ट्रॉन इज नॉट देयर. प्रोजेस्ट्रॉन का लेवल पहले ही फॉल हो गया. प्रोजेस्ट्रॉन लेवल जब फॉल हो जाता है, then endometrium is not able to become decidualized properly, so secretory endometrium होता ही नहीं है. ठीक है, and so patient starts having breakthrough bleeding before the actual menstruation in the form of spotting. So what happens? Patient starts having menses क्योंकि यहाँ से ही शेडिंग स्टार्ट हो गया, क्योंकि पेशेंट का सिक्रेटरी एंडोमेट्रियम हुआ ही नहीं. सो पेशेंट विल हैव स्पॉटिंग 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 अंटिल डे 28 के आसपास, जब पेशेंट को खुल के मेंसेस आ जाएंगे. ठीक है, सो डिफरेंसेस आप लोगों ने देख लिया है. फर्स्ट वाले में मेंसेस खुल के आएंगे, फॉलोड बाय स्पॉटिंग विच इंक्रीजेस द ड्यूरेशन ऑफ ब्लीडिंग एंड लीड्स टू AUB. एंड सेकेंड वाले में पेशेंट को स्पॉटिंग एंड ब्लैक डिस्चार्ज होगा एंड फॉलोड बाय खुल के मेंसेस आएंगे which again leads to AUB. So this is irregular ripening occurs because corpus luteum is not able to be maintained for its specified duration of time. So here what is the investigation of choice? Here we will get an endometrial biopsy done in the secretory phase. Okay, that is you get an endometrial biopsy done at day 21 to 22, at day 1 to day 21 to 22. इस टाइम पे आप एंडोमेट्रियल बायोप्सी कराओगे. तो normally in this case every patient should have got secretory endometrium, but अब यहाँ पे हमें क्या मिलेगा, सिक्रिटरी प्लस प्रोलिफरेटिव का मिक्सचर। सिक्रिटरी प्रॉपरली नहीं होगा, मोस्टली प्रोलिफरेटिव रहेगा, क्योंकि कॉर्पस लुटियम सही से बना ही नहीं, प्रोजेस्टेरॉन इज नॉट देयर। सो प्रोलिफरेटिव, गेटिंग प्रोलिफरेटिव एंडोमेट्रियम ऑन दिस पार्ट ऑफ द साइकिल इज पैथोलॉजिकल। सो दिस इज इरेगुलर राइपनिंग नहीं हुआ कॉर्पस लुटियम का प्रॉपरली। The treatment of choice is you give external progesterone support. Progesterone support has to be given from day 15 to day 25. 10 days in a cycle, give progesterone properly so that the body's progesterone जो corpus luteum से नहीं बना, corpus luteum नहीं है इसलिए वो आप बाहर से administer कर दो and the cycles will become all fine. So this is all about ovulatory type of bleeding. Two types of bleeding which I have already told you can do. If patient is not able to take only progesterone, patient is not able to remember day 5 to day 25, then you can give oral contraceptive pills also. मालायन या मालाडी स्टार्ट कर दो, उसमें भी आपके साइकिल्स रेगुलर हो जाएगा, क्योंकि फर्स्ट हाफ में ईस्ट्रोजन आएगा एंड सेकेंड हाफ में प्रोजेस्ट्रॉन आएगा। ओके, सो दिस इज AUBO. Next, coming to AUBE. AUBE is a diagnosis of exclusion. जब सारे exclude हो जाता है तो AUBE आता है। Basically AUB is endometrial causes, but except for endometrial cancer and endometrial hyperplasia जो कि AUBM में चला जाएगा, ठीक है। सो ऑल द मैलिग्नेंसीज को एक्सक्लूड करने के बाद बाकी एंडोमेट्रियल कॉजेज। सो बाकी एंडोमेट्रियल कॉजेज में क्या क्या है, बाकी एंडोमेट्रियल कॉजेज में है बेसिकली इम्बैलेंस बिटवीन योर प्रोस्टाग्लैंडिन E2 and prostaglandin F2 alpha. Okay, so basically what happens, there is a dynamic equilibrium between prostaglandin E2 and prostaglandin F2 alpha. Prostaglandin E2 is a vasodilator, whereas prostaglandin F2 alpha is a vasoconstrictor. So if you consider the endometrium, the vessels of the endometrium, then the vessels of the endometrium, okay, they can be dilated under the effect of local prostaglandin E2, and they can be constricted under the effect of prostaglandin F2 alpha. Once the blood vessels are dilated, then when they are shed off, when the endometrium is shed off, then patient will have heavy menstrual bleeding. Heavy menstrual bleeding will be there when they are dilated. But once they are constricted under the effect of prostaglandin F2 alpha, then bleeding will be minimum. So if due to any reason prostaglandin E2 local concentration of the endometrium becomes higher than prostaglandin F2 alpha, then the endometrium will become fluffy and the blood vessels will grow, and so that will be a cause of heavy menstrual bleeding during menses. Now this prostaglandin E2 and prostaglandin F2 alpha are the local concentration is increasing, so the blood levels, अगर आप serum levels कराओगे इनके तो वो normal आएगा, blood concentration is normal but the local endometrial levels are increasing. So this can never be diagnosis नहीं होगा इसका, so that is why it is always a diagnosis of exclusion. Okay, AUBE. So what is the treatment of choice? Treatment of choice is you give external NSAIDs like mefenamic acid, which will help in regulating the amount of prostaglandin E2 and prostaglandin F2 alpha, or you give tranexamic acid to the patients, tranexamic acid which prevents bleeding. Now what is the mechanism of action of tranexamic acid? It is antifibrinolytic. Always remember, it is antifibrinolytic drug. Okay, because it will prevent fibrin lysis. It will prevent lysis of fibrin. Fibrin is your factor 1. Fibrinogen is factor 1 and fibrin is activated form of factor 1. सो एक्टिवेटेड फॉर्म ऑफ फैक्टर 1 का जो लाइसिस है, ब्रेक डाउन ऑफ दिस फिब्रिन इज प्रिवेंटेड. सो फाइब्रिन अच्छे से बनता है एंड योर क्लॉट्स बन जाता है बॉडी में, तो ब्लीडिंग कम करा देता है ट्रेनिक्सेमिक एसिड. ओके, सो दीज आर द ट्रीटमेंट ऑफ चॉइस फॉर AUBE. नेक्स्ट कमिंग टू AUBN. AUBI is iatrogenic. AUBI is iatrogenic. These are small causes, so I have clubbed it into one video. Iatrogenic. Iatrogenic means anything which is induced by medication. Any medication, medical मतलब consequences के चलते पेशेंट को हैवी मेंस्ट्रुअल ब्लीडिंग है. लाइक इफ पेशेंट इज ऑन हेपेरिन थेरेपी, सपोज एंटीकोएगुलेंट थेरेपी, हेपेरिन ले रही है, वारफरिन ले रहे हैं, ठीक है, और एनी अदर एंटीकोएगुलेंट्स ले रहे हैं, ठीक है, थ्रोम्बोप्लास्टिन, पेशेंट इज टेकिंग थ्रोम्बोप्लास्टिन, all these derivatives patient is taking, antiplatelet drugs like your ecosprin or aspirin ले रहे patient. Okay, so these will lead to heavy bleeding. Also, suppose patient has undergone copper T insertion or multi-load insertion. After that, patient's का endometrium will become inflamed for the next 2 to 3 cycles. So patient can have heavy menstrual bleeding after copper T insertion. These all criteria come under AUBI, iatrogenically induced. So you have to identify the cause and do the treatment accordingly. Next comes the last one is AUBN. N stands for not otherwise classified. Not otherwise classified. Okay. So पहले के ज़माने में it was called not yet classified. Now it is called not otherwise classified. In not otherwise classified, you have the causes जहाँ पे और कोई कॉज भी नहीं पता चल रहा है, AUBE भी नहीं लग रहा है, ठीक है. So in AUBN, possibly N is also a condition whereby you cannot diagnose. But some of the causes of AUBN can be your isthmocele. Isthmocele, I have told you earlier also. What is isthmocele? Isthmocele is when there is tight suturing which is done of the uterus, anterior surface of the uterus during cesarean section. Suppose during cesarean section your uterine sutures have been very tight. So what it will do is it will pull the uterine cavity outwards. So what will happen? Your uterine cavity, anterior part of your uterine cavity will become like this. So there is indentation in the anterior part of the uterine cavity. So what happens is during every menstrual cycle the patient will bleed and a bit of blood gets collected in this isthmocele. In this isthmocele blood will get collected. Later on she will have black spotting or bleeding from these old clotted blood. It will keep coming out and will lead to abnormal uterine bleeding. So this is called isthmocele. The treatment of isthmocele, investigation of choice is either ultrasound maybe it is diagnosed. Ultrasound से अगर conclusive नहीं है, you can go for an MRI also, but the diagnosis of choice is ultrasound. Gold standard of course will be hysteroscopy. Hysteroscopy is the gold standard because in hysteroscopy you can directly visualize it from the interior कि there is niche है कि नहीं. It is also called as cesarean section niche. Cesarean section niche, NICHE, niche is the other term for isthmocele. So whenever there is niche, what you have to do is you have to just scoop out this. You have to just scoop out this endometrium so that you make this cavity large. If you scoop this out, it will become like this and it will become blunt, so the bleeding will never get stagnated. Okay, so this is the treatment of isthmocele or cesarean section niche. It is due to defective cesarean section scar when the suturing has been done very tight. Apart from that, other causes of the N can be your hypothyroidism. Hypothyroidism can also lead to heavy menstrual bleeding in most of the patients. So always get a thyroid profile T3, T4, TSH done for patients. If they are hypothyroidism and you start medication, L-Troxin or thyroxine is started, then patients symptoms relieve. Also, some systemic illnesses like patients of leukemias, okay, and then injudicious use of hormones, patients, somebody is taking external hormones very injudiciously, then they can also have heavy menstrual bleeding, and they all come in this. Also, patients of tuberculosis, patients who have genital tuberculosis, I have a separate video on genital tuberculosis. You can see that in simplifying OBG session short lectures. So genital tuberculosis patients, what happens is, in the initial phase of the genital tuberculosis, when the endometrium is very inflamed, then patient will have heavy menstrual bleeding or menorrhagia hoga. Then later on, धीरे धीरे करके there will be scarring of the endometrium, and endometrium will become stiff, and later on patient will have oligomenorrhea, हाइपोमेनोरिया मीन्स बाद में चल के ब्लीडिंग धीरे धीरे कम हो जाएगा, एंड देन फाइनली पेशेंट विल हैव एमेनोरिया, and then patient will not bleed because the endometrium is damaged by tubercle bacilli. So initial part of heavy menstrual bleeding होता है, initial part में inflammation होता है, and patient has heavy menstrual bleeding, followed by धीरे धीरे oligomenorrhea, hypomenorrhea and amenorrhea. So this phase of the genital tuberculosis also has heavy menstrual bleeding. So these are some of the things which you generally investigate and treat in Cohen system. I hope you have understood. If any doubt, anytime you can let me know. Thank you for listening to this.